Okay, so this is the patient with lung cancer, and then the patient got an MRI. Any thoughts?
I see some hepatic cysts.
Mm-hmm. So focus on the adrenal gland.
Oh, we're supposed to look at the adrenal.
Sorry, yeah, there's
like a fat containing.
There's like, yeah. Right, so there's an adrenal lesion, which drops out on a post-phase imaging. And then there's a different signal, medial aspect of the adrenal gland that spares, that does not drop out on a post-phase imaging. So the patient also has a CT. And the CT shows this. So that area in the medial aspect of the adrenal gland takes up activity right there. So this is.
Wait, are you even on it? Hold on, go back.
It's like a collision tumor.
Oh shoot, sorry, it's like duh.
Okay, got it.
There it is. Right. Right. Yeah, exactly. So Victor, where is my? Yeah. So yeah, adrenal collision tumor. So that's like when you have two histologically distinct findings, and it could be benign, malignant, or malignant. So in contrast, I guess there's this condition called composite tumor, where you have two lesions that sort of grow simultaneously. Typically, they see that with like adrenal carcinosarcoma, where you get sarcomatous change within an existing carcinoma. So adrenal collision tumor, it's most commonly two benign etiologies, like an adenoma with myelolipoma. But for patients with cancer, like mine had lung cancer, so you sort of have to have a high level of suspicion, especially when there's change. And MR can be very helpful, as can PET and CT. So here's an example of a collision tumor in a patient with RCC. The patient also had an adrenal collision, like a MET, in a patient with like adenoma in the background. Here is an example of a patient who had sort of just an adenoma and then developed breast cancer and then developed a MET to that prior area of adenoma. Here's another example. This is similar to my case, patient with lung cancer. So patient has lung cancer, and it has an adenoma, but there's also this high isoattenuating MET we see that has similar characteristics to my case. But we have to be careful because patients with adrenal hemorrhage can also have very similar imaging findings, hyperattenuation with the area fatty, like there's absence of signal dropout. But with hemorrhage, it should go away or improve over time and get smaller, as happened in this case.
I have a question.
Yeah.
So like you can have also just heterogeneity, right? Like if like, for example, that PET had like an adenoma doesn't have to have like fat throughout the whole thing, right? So if that PET had not been so hot, do you think this could have just like, it could all just be like an adenoma? Like it can be that heterogeneous, correct?
Probably, but this one it had like homogeneous fat before, and then later developed the heterogeneity.
Yeah. The old exam is usually like.
Yeah, exactly. So, yeah, it's possible. But in this case, the patient didn't have that. But yeah, sure. But I mean, if it's heterogeneous, it should still all drop out, right? Or is there also?
No, I guess that's what I'm asking, because I feel like a lot of adenomas I see, you don't see like the whole thing drop out. You see maybe some areas, but other areas that don't.
I see. Yeah, it's possible. What about Victor or Melina? Have you guys seen anything like that?
The collision tumors?
No, not collision, just like heterogeneity in like
Uh-huh.
you don't need to have the whole adrenal adenoma
Yeah.
drop out in order to call it an adenoma.
Right. Not all of it does usually.
Yeah.
Cool.
It's usually heterogeneous.